where the aim is to educate, empower and equip you with the knowledge that you need to live your healthiest life. Today I'm here with Dr Stacey again and we're talking about endometriosis. So if you're here last week, we spoke about fibroids and I had the amazing Dr Stacey Gynaecologist, she's here again, and she imparted some gems, some words of wisdom to us about fibroids and how they present, which is one of the most common gynae problems. Now, if you don't know Dr Stacey, she has her own Instagram page called caramel_Dr7.
Yeah, that's right.
Where she gives some amazing tips on there, and she is a senior registrar doctor in obstetrics and gynaecology and has years of experience. How long have you been in obstetrics now?
Oh, since 2013.
So you go.
8 years.
8 years in obs and gynae, so definitely so much information that you're able to share with us. And we spoke about fibroids last week, but another condition that I get a lot of questions about is something called endometriosis, and I've got to be honest, it's a condition where I sometimes feel at a loss with.
Yeah.
It's not that easy to diagnose, especially for someone with not many tools, a GP. I sit in a room, diagnosing endometriosis with that, with the tools that I have is quite difficult, and it really can affect some women quite drastically. And so I often have women coming back with different symptoms and we find out it's endometriosis, and it's quite a difficult condition from what I've seen. So I wanted to give you a little bit of a background about endometriosis, but what I did, we put a question sticker on our stories, and we asked questions about endometriosis and fibroids, and we got quite a few. Actually, you can tell that it's not as well known as fibroids because the questions are more towards fibroids and less about endometriosis. I think that's because it's just not understood that well. And so we're going to go through those questions,
Sure.
if that's all right. But I thought at first we'll just give a little background about what endometriosis is. So endometriosis, it is a chronic growth of the uterus lining, what we call the endometrium, but outside of the uterus. There are different types, and from what I understand, the different types are based on where the growth is happening.
Yeah, just usually location.
Yeah. So what I understand, most of the growth usually happens within the pelvis.
Yes.
But there are some cases where there's growth outside of the pelvis. So the pelvis is that lower abdominal area, so sometimes it might be around the ovaries, or it might be around the back passage of bowels, around your rectum, sometimes around the bladder.
Yeah.
But it's basically a growth of that outside. But there are, I think, I've seen it on a program once actually, somebody had some endometrium that was growing in their nose, and they were having nosebleeds during every cycle, and they couldn't understand why they were getting all these nosebleeds. So
there's a patient who had it in their thoracic cavity actually, and they had a pneumothorax, which is a collapsed lung every single month.
Wow. Yeah, so it does happen. It does come out in different places. I haven't seen anyone with it in any of those unusual places, but it's just a growth of this uterus lining outside of the uterus. Now, it's one of these things that, from what I understand, the cause of it is still not fully understood.
Not fully understood. We think it may be due to what we call retrograde menstruation, which is just backwards menstruation. So normally when you menstruate, you shed the lining of your womb, it all exits out through the cervix, but occasionally it can go backwards and out through the open ends of the fallopian tubes and enter the pelvic cavity that way.
And so there does seem to be as well, for I understand, a bit of a genetic component to it too. I believe that if you do have a first degree relative that has severe endometriosis, there is more risk that you would have it compared to somebody that didn't have a first degree relative with it. And I've seen that they've done some twin studies that show that there does seem to be this kind of familial or genetic component to it as well. But the reason why I find it such a difficult condition to deal with is on average, it can take up to 7 years?
7 years, yeah.
7 years from the start of symptoms to actually getting diagnosed with it. And the symptoms, they can really vary quite vastly depending on where the endometriosis is. And I believe it doesn't always correlate to the amount of endometriosis.
That's
the
right.
symptoms don't often correlate like that.
Yeah.
And so the symptoms may be having pain, so having painful periods, having pain during intercourse, having pain around wherever it is, so irritation to the bladder, I understand, you can get UTIs and things with it.
Yeah, you can bleed you can have blood in your urine as well with your cycle. Same with the bowels, if it's affecting the bowels, you may have blood in your stool. You can get, you've already mentioned, really deep pain during sex, so deep as opposed to superficial. And you can get chronic pelvic pain as well. It often starts off as just being associated with the cycle, but as it progresses, you may find you just have chronic pain all the time.
And that's what I find difficult about it, because although you have what I usually think about with endometriosis, that's with the cycle. So these symptoms, they flare up every time, like just before or during your period, that's when it flares up. But then you do get to the point where it's just kind of this mush of symptoms that are just there all the time, and the woman's really struggling with it, and you don't know what to do. And there's so many other conditions that mimic some of the symptoms, such as inflammatory bowel disease, because it can cause diarrhea and bleeding in the bowels as well. Also, things like pelvic inflammatory disease as well, this chronic pelvic pain. And so there's often a lot of things going through our mind, because you've got to remember, whenever a patient comes to me, they're coming with just symptoms, and we haven't been able to put them into a category yet. And so trying to figure out, is it the bowels, is it the bladder, is it something gynae? And getting through that all can take a little while. And then once we actually do realise, or think it might be endometriosis, it involves a referral, because although we can make an educated assumption that it is, I understand that the best way to test for it, and the gold standard really, is to do a keyhole surgery, to have a look to see if we can see the endometriosis. So there's a lot to it, and that's why we have an expert here who can tell us a bit more about endometriosis. So let's get into the questions. So the first category of questions are all about the diagnosis of it. As I said, it's hard to diagnose, it can take years to diagnose. But someone asked, why is there so much misdiagnosis? And are there any other ways to diagnose it apart from surgery? I think I kind of alluded to why it is so difficult. Because first of all, you need to get in front of the gynaecologist, and we need to make sure we know that it is a gynae problem and not a bowel problem or a bladder problem or whatever other problem. But what's your take on this misdiagnosis or delayed diagnosis?
I mean, there's been a lot of publicity about that recently, hasn't there? There's been lots in the newspapers, a lot of women coming forward saying, I've been in pain for ages, no one believed me, I didn't get a diagnosis for years. But I don't really think it's as straightforward as no one believing you or people not having endometriosis in the back of your head. I think there's a couple of reasons. So the first is, some people don't necessarily know what's normal, so they may not present to you as a GP for a long time actually. They may be just struggling along. When you learn about periods in school and that before you've had your first one, you often get told it's painful, so you expect pain. And to be honest, some degree of pain is normal for a lot of women, and it's just due to the way that your body reacts during a period, releases all these inflammatory chemicals, and that irritates the nerves surrounding the uterus and causes pain. So some degree of pain is normal. So that's the first thing, people not knowing what's normal. Secondly, as you've alluded to, it can mimic a lot of other conditions, or there's a lot of symptom overlap with other conditions. Like when we think about chronic pelvic pain, for example, as many as 50% of women who come to gynae clinic with chronic pelvic pain will have symptoms of IBS. So there's a lot of overlap between endometriosis, chronic pelvic pain, pelvic inflammatory disease, irritable bowel, and as you said, it can be quite difficult to sort out all of those symptoms into the right category. And besides, the woman may have multiple things going on as well. And then I think the third thing is, although women may find they've not been diagnosed formally up until about 7 years, they've often had the treatment started. So it's not like they've just been left all that time. When you think about the guidelines, the national guidance, is actually not to go straight ahead and do keyhole surgery, because it's surgery and the side effects. If we have a suspicion, just go ahead and treat, and that's usually with your hormonal things. So the pill can use things like tranexamic acid to reduce bleeding. So we are already starting to treat the symptoms, and NICE, the organisation who kind of gives us that guidelines and tells us when we should be referring, says to only refer if either the patient's very young, so under 17, or if treatment is not being effective. So you do definitely start things as a GP, and often, certainly when I see the women, they've usually tried one or two things before they come to me.
No, absolutely. And you're right, even though it's a condition that's difficult, because actually getting that label is difficult. Often the things that you need to do to treat endometriosis, which we'll go on to in a minute, we are doing them in general practice. You know, we are trying to manage your pain, or manage if you are having bleeding, or trying to give you some kind of contraception if you need contraception, to try and balance things for you. And so those things are happening, but getting the label right and knowing that's actually what you're dealing with is where the difficulty does lie sometimes.
You asked about diagnosis as well. So having laparoscopy, which is a keyhole surgery into your tummy, that is the gold standard, because we need to see it to diagnose it. Often before you get to that point, you will have had an ultrasound scan where we put a probe on your tummy. You may need a probe in the vagina as well, so we can have a closer look. The only evidence of endometriosis we can see on the scan is if you've got big cysts called endometriomas, if you've got adenomyosis, which is where the endometrium implants into the muscle layer of the uterus, or if you've got what we call really deep infiltrating endometriosis, because then the masses are big enough for us to see on scan. But if you've only got superficial, I should say only, because it's not to say that it's not important or less debilitating necessarily, but if you've got superficial endometriosis, which is what 80% of women will have, you can't see that on scan because the deposits are too small, which is why the gold standard for diagnosis is keyhole surgery.
Exactly. And you're talking about the cysts, just because I did do a rotation in gynaecology. I did like 4 months in there, and a few years ago, I think it was like 6 years ago now. But I remember I did go to some surgeries where they were doing this, and I remember one woman, she had this massive ovarian cyst, and we called it a chocolate cyst. And
it's really bursty.
Fountain. It was a wonderful experience. And so I do remember that, absolutely. And I'm sure that was definitely picked up on an ultrasound scan before she actually went through to surgery. Now, we did allude to a bit of treatment before. The first question that we got about treatment was, is surgery the cure?
Is it the cure? Well, the question is, can you ever really cure endometriosis? Certainly, a lot of the women that I see would have had surgery for it before. And they're coming back for repeat surgeries. They may end up with 2, 3, 4 laparoscopies until eventually they go through menopause when all the symptoms quiet down, or they may end up with hysterectomy if they're really struggling. So we mentioned medical options beforehand. They don't really cure it, as in to get rid of it, but they definitely help the symptoms, and they do that by switching off the ovaries. Because when you think about endometriosis, it's the same tissue as what's lining the uterus, so it responds in the same way to your hormones every single month, which is why you get the symptoms. So the medical treatment that we use aims to switch off the ovaries, stop that hormonal cycle happening every month, and therefore stop the symptoms. If that's not working for you, then yes, we can offer you surgery. A lot of women pin their hopes on it, but a high proportion of women, I think as many as 50% of women with chronic pelvic pain will have what we call a negative laparoscopy. So we'll go inside, we'll have a good look around, and there's nothing there. And we also talked about how the amount that we see doesn't correspond to severity. So you may only have a tiny spot, but be in loads of pain every single month. Your pelvis may be totally fixed, and you're absolutely fine, and it was just an incidental finding. So it can be really variable, and that kind of makes it difficult to treat.
And I think that's a big criticism that I've heard from patients and just like out in the public, of doctors being too outcome orientated, or not wanting to do all these different procedures and things, and not really sorting out a problem, or the doctor said that I wasn't struggling enough for me to get this surgery, and all those kind of things. And I think it's really important to remember the impact of having these done, the impact of having these surgeries, because I've heard these criticisms of, they're just giving me hormone tablets, they're just giving me contraception, and they're thinking that's fixing it, I want them to fix it. And I've heard that complaint a lot from people, but it's to remember the implications of what we're doing, the risks that are associated with everything. Even though it might seem like this surgery that might fix things, we know that a lot of the time it may not fix things, and then you've gone through surgery.
Because we've gone in, and just by nature having surgery will cause scarring. That can cause more pain. If you get scarring by the bowel, you can get bowel obstruction. Like, I think a lot of women, as you said, can often think about surgery quite lightly. And I'll just go in, I'll get it done, it's keyhole, I'll be home later that day. But often it's not that simple, and I think it's really important for both sides to have realistic expectations about what they're trying to achieve as well. I mean, we know that there's quite a large component of pain and the way we respond to pain, not just in endometriosis but in general. There's quite a large psychological component, but we find that patients are really resistant a lot of the time to trying things like cognitive behavioural therapy or counselling, because they feel that we think that it's all in their head, which is not what we're saying at all, but we just know that there is proven benefits to using these strategies because it does deal with a component of pain.
Absolutely, and that was the point that I was going to bring up as well. What you said at the start about women and being very, you're told that when you have periods it will be painful, so some people will just take the pain and not come and get any help when they really are struggling. You also have the flip side where somebody is having maybe what some might call quite minor pain or minor symptoms, particularly about heaviness of bleeding. And someone might find it very distressing, the amount of bleeding they're having, and another person with the similar amount would find it completely normal. So much of it's subjective, and it's not to say that us as doctors or as medical professionals are trying to kind of dismiss your symptoms or feelings, but often these additional cognitive things trying to help with the psychology that goes behind dealing with chronic conditions like this, it's not to fob off the patient, it's actually to support you. It's actually to give you those tools that you can manage it, because a lot of these chronic diseases and chronic symptoms, they can't be fixed like that. Exactly. It's not realistic to think that can happen, and so unless we do the work to help you to manage with those things a bit better, then you're likely to struggle a lot longer. And so that's an important thing to say as well. So. And another thing that was quite a big part was asking about fertility. So I think there's a lot of, most people, they'll get pregnant usually within the first 12 months of trying.
Yes. I think it's 80%.
80%, yes. 80% of couples will get pregnant within the first 12 months of trying. But a lot of the time, now that we have so much access to, it was already an issue, but now we have access to social media and we can see what other people are doing, and you start to make assumptions of how easily someone else found it. Often these things of fertility issues is becoming more wide known, and people are getting more worried about it and concerned, and there's more conversation out there. And so sometimes fertility is always on people's minds now. People want to start families, they know that these things are out there, and often people are looking for answers to why they're becoming infertile, and that's why there's always these questions with any gynecological condition: what's it going to do to my fertility? What's going to happen to it? A lot of the time, infertility or subfertility, there's many people that don't get an answer, and so it's not to say that if you're struggling to have a child that it's definitely, we're going to find something, and so sometimes that's something to get your head around. But endometriosis, I know that there is sometimes some issues with fertility with that.
So the difficulty with endometriosis is that both the condition and the treatment can impact fertility. So a lot of women have quite a difficult choice to make as to whether or not they want to do anything or have conservative management. Endometriosis itself, the last figures I read were that if you have what we call mild or moderate endometriosis, your chance of spontaneously conceiving is 30%, which is really quite low, I would have said. If you have severe endometriosis, then that's as low as 0%. So then you may really need some help. The reason why I was saying treatment can also impact your fertility are some of the treatments that we use to switch off the ovaries, put you in an artificial menopause. It's reversible, but it just means that while you're on that treatment, you wouldn't be able to try and get pregnant. Also, endometriomas, we mentioned those big chocolate cysts. When you have them removed, so if they're causing you problems, or if your gynaecologist advises that you remove them, what you have to remember is that when we're removing this cyst, there's always a chance that we're going to remove a little bit of normal ovarian tissue as well. So if you already don't have very many eggs, which is not something that we routinely test for preoperatively, then that can impact your fertility. And particularly if you have bilateral cysts and we have to remove both of it, your risk of going into what we call premature ovarian failure after that is about 2.43%. So it's something that definitely does take a lot of serious consideration.
Absolutely.
Just before we finish, sorry, I was going to say diet is usually something that we get asked about.
No one did ask a question about diet this time, but
I have been asked before, is there anything I can do diet-wise to help endometriosis? I've heard lots of anecdotal stories about people who have cut out dairy, gone vegetarian or vegan, they've really found that helps their symptoms, and that's also backed up by evidence as well. Again, women who have a higher fruit and veg intake, less red meat. There's also some vitamins that are associated with it. I think vitamin B12, vitamin C and vitamin E have all been found to be really helpful with those symptoms as well. So that's also something you could try.
Brilliant, thank you. See, so much knowledge just keeps coming. There you have it, guys. Endometriosis is a complicated one, but I hope that these videos that I've done with Dr. Stacey will give you a bit more knowledge and feel a bit more empowered to ask questions, to ask for help if you do need the help, and to know what kind of signs that you're looking out for. So guys, I really hope you enjoyed this video, but there is one last question that I wanted to kind of address, and it's not to do with endometriosis and it's not to do with fibroids, but this question was, do you guys ever get any issues that your patients have? For example, the different types of discharge. I saw this question, I thought this is so interesting because we're humans. We can't escape, a lot of these things, you can't escape disease. And even though there's so many diseases and conditions that are out there that are to do with lifestyle, things that we do in our lifestyle, even though we might know the information, a lot of these changes are hard, they're difficult, they're difficult to keep up with, like all the healthy things that you should be doing, especially when you have quite demanding busy jobs like we do, and if you've got children at home like we do, it's hard to obviously, so illness can come out our door, it's something that happens.
Definitely. I think it makes us better doctors though.
Definitely.
I found, particularly in my specialty, having some of the issues that I had during pregnancy. So for example, I was always sympathetic to the hyperemesis patients, but when I first got pregnant and when that nausea and vomiting hit, let me tell you, I felt differently sympathetic for those women. And literally every time I go through something, I feel that it gives me another layer of understanding.
Absolutely.
So that when I see those women again in future as my patients, I feel that I'm a better doctor for it.
100%. I think if we were just floating around, never getting any of the things that we spoke about, I don't think we'd ever do justice. And honestly, you can still be a doctor and not have those conditions. Like I treat men that have, conditions that I could not get as a woman, and I can still treat them. But actually having that empathy of, I've got a condition, in my pregnancy I had pelvic pain, and now when I do my baby checks, my 6-week baby checks, and I talk to the mom, and I examine the baby, there's so much more I can give them.
Definitely.
It's like a completely different story than that with my daughter. I feel like I'm a different doctor.
Person. It adds a completely new dimension, and I just think it makes us so much better.
Definitely. So to answer your question, yes,
definitely,
we do get them, but it's all part of life. But thank you so much for joining me for these 2 videos.
That's fine.
If you're not already, please go over to Instagram. Make sure you follow Dr. Stacey _Dr7. It'll be just here. And don't forget to like and subscribe. Come back, we've got more content for you. And if you want Dr. Stacey back again, if you have any more questions, please just leave them down below. Like this video, and thanks for watching.
Thank you very much. Bye.